Hello everyone, I'm AJ and I'm going to be talking to you about bundle branch blocks. And this is a very common terminology in ECGs. Concerning ECGs, you have about left, right, and all other types of bundle branch blocks. And so today we're going to be demystifying it. Um, so this is how we've described this diagram before. This is where the sinoatrial node is. The sinoatrial node is um, So this is the sinoatrial node in the right atrium. Then it goes to the atrioventricular node through the anterior internodal tract. And then from the atrioventricular node, impulses are passed to the ventricles through, first you have the right bundle branch, which goes to the right ventricle. Then you have the left bundle branch, which goes to the left ventricle. Then it terminates in small, it's not labeled in this diagram, but it terminates in little tiny fibers called the Purkinje fibers that land on both sides. You also have the middle internodal tract anyways. So when the anterior internodal tract is sometimes maybe sick or diseased, the anterior internodal tract serves as another pathway through which electrical impulse can travel, right? Then we have the Bachmann's bundle, and this is very significant when we talk about other accessory modes of impulse transmission. The heart is beautiful in the sense that it has a backup plan for if the sinoatrial node is not able to generate the impulses, or if for one reason or the other impulses are not generated through the main pathways. Now, the right coronary artery, the proximal aspect, supplies the sinus nodal artery, and the left anterior descending artery handles the right bundle and front of the left bundle. The posterior fascicle gets double backup from the left anterior descending and the right coronary artery. The posterior descending artery powers the AV node and the bundle of A's. And the bottom line is that when one of these back arteries is blocked, it's like pulling the plug on your electrical circuit board, on the wiring of the heart. Like when you disrupt wires, maybe between the television and the wall, you don't get signal transmitted to the television, do you? So there are all this electrical wiring in the circuit board, and when you snap one of the wires, you're pulling the plug on the electrical supply of the heart in that region. Now, there are several morphologies that you need to be familiar with. I think this is the trick. This is the main trick with understanding. You see the RSL, QS. So when one of the letters is dominant, it means that the dominant is whenever it is in capital letter, I mean that means there's a dominant phase there. So this is a QS, these are all QRS complexes, so to speak. And I discovered not just me, the people I teach used to be confused with identifying what's an RSL pattern, what's an RS pattern, what it basically means. For example, when we talk about this pattern is that the Q is dominant, so we know that this is the normal. Scratch that. So we know that this is what, just permit the inaccuracy of the drawing, but this is what the normal wave would look like. And we know that this is our P, this is our Q, right? This is our R. Like I said, I'm just trying to annotate as much as I can. This is our S, and this is our T. So this is the QRS model here, is what we're trying to represent. But there are many times where you have a dominant Q and you don't see much of an upward deflection that represents an R. So here we have the QS pattern. Here you have a Q, but it's small, and the dominant part is R, and you're not really seeing much of an S. There's no come up. We see our S here, and the S is not present here. Then this is the QR pattern. Here we have a prominent Q and a prominent R, but not much of a deflecting S going downwards. So here, this is the QR pattern. Here you have a much more dominant Q and just a very little R. This is the QR pattern. Now, this is the QRS pattern that we know. This is what is normal in many respects. And even this Q many times is not present. When it becomes present and it's becoming a quarter, more than 25% of this entire R wave, then we say that, it can be a pathologic Q wave, but this is what we will draw for a regular QRS complex. Now, here you don't see a Q, you don't see a proper S. This is merely an R wave that you can see, and that's why you just have an R. Here you have an R and you have an S, right? And many times we will also find this has normal in many leads. Now, this is a small R and a bigger S. Now, you find this in your V1, V2 because you should have steady R wave progression in your precordial lead, shouldn't you? And here you have a bigger R and a smaller S, right? And of course, you have your QRS. In this case, there's a small Q. Now, this is a big letter R. So there's a small Q, but there's a big R and there's a small S. So just for you to be aware that this is how we would be describing. This is important for you. I know we talk about the William, but this will help you understand if they're talking about the RSL patterns and you're seeing capital letters over the place. So let's talk about the right bundle branch block. I'm going to stop annotating and try and move this cursor away. So right bundle branch block just talks about, that your QRS duration should not be more than 3 small squares. That's 120 milliseconds. So when it's 120 milliseconds or more, then you should be looking at, do we have a bundle branch block here? And then what you see is your RSL pattern. Remember what we talked about RSL pattern? You have a small, okay, I was going to draw that for you. Remember what we said when we talk about a RSL pattern. Remember here that there was no Q, right? So we had this R, right? We had a very big S, right? And then we had a very big R as well. So this is what you'll be having. And that's why we talk about Maro-William. I don't want to write the whole of Maro, but we talk about Maro-William, right? Because it looks like an hem. You have this, there's no dipping of Q, a small Q, a small R, a big S, and a big R as well. So, and this is what you will have in your RSL pattern. You have a notched R wave, and this is what they mean by like a notched R wave in V1. Of course, then you have a wide S wave in V1 and in V6. So this is what I was trying to describe. Where's the RSL pattern here? Okay, it's not here, but basically you saw how we worked out what an RSL pattern would look like in terms of morphology. I think I should have a diagram of that very soon. But the course is, so what you have is that and what some people will say that it looks like bunny hairs, right? Like bunny hairs, and a wide S wave in leads 1 and V6 because the S wave is so wide. And so what do you think you'll find in an S wave? Let's assume that, this is, remember that your S wave is what positively deflects. So whatever happens, you're expecting to see a very wide S pattern, a very, prominent S wave, a S that is really quite wide, right? Okay. So, moving forward. So a right bundle branch block it can be normal. About 0.2% of adults have it naturally, and sometimes it means nothing serious, right? But it can mean a heart attack. That's where the problem arises. And it can be due to long pressure overload. So the way you think about it is right heart, right? Right, it could cause core pulmonary, COPD, pulmonary embolism, anything that causes some long pressure overload and right heart strain. Also, it can be seen in ASD or Einstein's anomaly. Some other times, and that's why even the other day I did a presentation on differentiating a wide bundle branch block from Brugada syndrome. Very rarely, your Brugada sailboat shaped pattern or shark fin shaped pattern what people cannot differentiate is whether there is actually that notching or whether it is a cove shape. So sometimes it can be rare. You can find a wide bundle branch block in Brugada, and you're seeing it as an evolving Brugada, right? So RBB is usually very benign, it's usually very chill, but during an acute MI, especially if it is new, it can be a bad news. So if you're seeing a right bundle branch block that you're not seeing in older ECGs, or they're symptomatic of a cardiac sounding chest pain, it can be screaming proximal left anterior descending artery occlusion. Key takeaway is that right bundle branch block does not ban you from the treadmill testing. But if it's new and the patient is in pain, please call for help. So here we see, right, so what you're really looking for. So whenever you see a wide QRS complex that is 3 or more small boxes, start looking out at your V1 and V5 and V6, right? And as you can see, we see the bunny ears here. It's in V2, very classical. Oops, I was going to show you. Yeah, it's very classical in V2. So you can see, of course, in V1, you can see the RSL pattern we discussed. You had a small R, right? A very good S and a bigger R, right? So you could find it in V1 and see how the classical bunny ears are in V2 as well. And then when you go to your V5 and your V6, what do you see? A dominant S wave, right? A dominant S wave. So we know that the arrow is somewhat there, but you also have a dominant S wave, and this is what you will call a right bundle branch block. So what some will say, so we talked about the RSL pattern. In V6, you can call it a QRS pattern. So if you look at here, right, a QRS pattern, remember that this is a capital R and a capital S. So basically, that's what you're looking out for. So a QRS pattern. Oh, sorry, I meant not a capital S. A small Q, a big L, and a smaller S. And with the left bundle branch block, remember that your QRS duration is still wide. So, like I said, if you're using the right method, you're doing the rate, reading, axis, interval, injury, and context that I have taught and that I used in teaching, you would realize that once you get to the QRS, once you're on your high and you're doing your intervals, when you measure your QRS and it is indeed more than 3 small squares, go to your V1, go to your V6, go to your lead 1 and see what is going on there. So what you have is a broad Howe wave in 1 and V6 and a prominent QS wave in V1. Absence of Q waves in 1 and V6, including physiologic Q waves, and I will explain that in a bit. So this is a left bundle branch block. As you can see, it's an RS pattern. So what did we discuss again in terms of interpreting this RS? And this time around, I will draw it with this in mind so that you can see that carefully. So in terms of the morphology, what you would have is a small hair. So you see there's a little hair here, and of course, there's a big S, right? And that's what you will find. But in your V6, and that's why we call it William Marrow or left bundle branch block. So left bundle branch block is William Marrow, right bundle branch block is Marrow William, right? So here, what will you find? You find a big R, right? A small S and a big R again. So, and that's it. That's how you will, and that's what you will find in your V6. But let's go back to what are the causes. Now, left bundle branch block is never normal. It is always pathologic. It's the diva of bundle blocks, and it's never just. It's always coming in with either with a coronary artery disease, or dilated cardiomyopathy or aortic stenosis. Most commonly, I have seen it in people with high blood pressure. One of the workups we do with newly diagnosed blood hypertension is we do an ECG. And what are we looking out for an ECG? one of the classical findings with someone that has had undetected hypertension for quite some time is the left ventricular hypertrophy. Even in your older patients that have had hypertension and have been managing it for quite a long time, look at the ECGs, you will most likely pick up a left bundle branch block. You can also find it in people that have artificial pacemakers. It just means the left ventricle is in trouble. It's waving a red flag. It's developed muscles, just like the name sounds. And now the clinical significance is that it can be an indication for thrombolytic therapy. But it's sneaky, it's sneaky in the context of a left bundle branch block when you are not sure that, you're seeing other things. It can be the first telltale sign of an MI. And you can't use the usual LVH tricks, right? If you see left bundle branch block in a patient with heart failure, it's called ventricular desynchrony, I mean, because the heart timing is off and it matters, right? So again, as we can see here, remember that we've mentioned that here what we have in terms of, now, if you just wanted to look at it in terms of the W. William Marrow, that's very easy. Just look at the morphology, it looks like a hem, and look at this one, looks like a W, right? But if you wanted to interpret it using this pattern, remember that we said that remember that we said, right, that there's a small R and a big S. So if you look here, what do you find? You can barely make out any R here, right? But they say a big S pattern. So the problem with left bundle branch block is that big S pattern that you see. You find a very big S. Here, the smaller is barely evident, right? And what makes it worse is that there's poor R progression as well in this ECG. The R does not progress as much as we would like it to do through from V1 through V4 and the rest. But when we get to V5 and V6, what are we seeing? You're seeing this RSR, which is what we discussed, RS, and a big R. And so you have a big R, a small s, a big R again, and that's where you get your William Marrow from. Now, diagnosis of MI in the presence of left bundle branch block. So the problem with left bundle branch block is that it is very difficult for you to interpret it in the context of an ST elevation. So look at this, for instance, because of the prominent S wave, it can be a bit tricky. Is there ST elevation here? You might put your ECG ruler here and think that, okay, there's one or two, but many cases are not very straightforward. So it can be daunting. So when you have a left bundle branch block, what we advocate you do is to use your Scabosa criteria. And basically, there's a way I like to summarize Scabosa criteria. A mismatch is normal. That's what we mean by discordant. So when your ST segment is discordant to your QRS, that means they are both facing opposite directions, right? It's normal to a great level, but when they are concordant, when they are both, either negative or both of them are either positive, then there is a concordance, and that is abnormal. And that is why Scabosa scores that even if it is 1 millimeter of ST elevation, for example. So let's check out the first Scabosa criteria with the ST elevation in the last ECG. So what you will find here, right, is what I want you to look at, right, through V1 and V3 is the QRS complex. Is it in the same direction as this ST segment elevation? What you expect is that if there's ST elevation, then the QRS should be negative. So the QRS there's a bit of ST elevation, right? But the QRS is negative, right? So that's fine. That means it does not fulfill one. Because if they are both facing the same direction, then it is concordant. And Scabosa scores it 5 points immediately for that, right? If the ST segment if you have ST depression, right, in let's V1 to V3, then what do you expect ideally in a normal ECG? If they have ST depression, you expect that the QRS should be positive. Also, if you look at ST, if you check the ST, now, when we've already said that discordance to a level, to a high level is normal, but when the discordance is more than 5 millimeter, then Scabosa scores that too. So even though they are facing opposite direction, the ST segment elevation should not be up to one big box, that's 5 small squares. If the ST elevation is that massive, regardless of whether it is concordant, discordant, you already know you're dealing with an ST elevation MI there. So we can then talk about left anterior ME block. Now with left anterior ME block, right? Oh, bless you. Sorry, I just had a little yep. Yes. Okay, so as I was saying, with the left anterior ME block, if it is a small block, it's a big deal. A left anterior ME block just refers to a partial block, a partial left bundle branch block, where the anterior division is blocked. So what are you looking for here? You're looking for left axis deviation. You're looking for this small letter Q, big letter R morphology in leg 1 and AVL. You're looking at the small R, big S morphology in 2, 3, and AVF, the inferior legs. So this is a Q1 S3 pattern where you have a Q, what looks like a pathologic Q wave in lead 1, and also the prominent S wave in lead 3. Then you could also have slowed S waves in the left precordial lead. So these are the classical findings that we have described. So look, we said there will be an S in 3, right? We said there will be a Q. We did mention that there will be a Q in 1. So there is a Q here in 1, but sometimes it's even more prominent. And there is an S in 3. You can see there's a prominent S wave in 3, and also in lead 2. Not forgetting that we see this small R, big S phenomenon. So a small R and then a big S in lead 2 and lead 3, as you have noted here, right? So this can be synonymous with a left anterior ME block. Now with a left posterior ME block, okay, we're still talking left anterior ME block here. So left anterior ME block can be a normal variant, right? Sometimes it's just a bystander, but sometimes it could mean IBP, cardiomyopathy, anterior MI. It can also mask old inferior MI signs. If you've noted what we've been going to about 2, 3, let's 2, 3, and AVF. You know that what happens in 2, 3 AVF, even if the QRS wasn't wide, 2, 3 AVF, if you saw an ST elevation, it would alert you to an MI, right? And again, where you get an ECG, you're not probably seeing any classic ST elevation, but you notice a wide QRS complex in 2, 3 AVF. You should actually ask, about the context and try to investigate fast and deeper. So it can be a normal variant, but it could be masking an old inferior wall MI by abolishing the diagnostic Q waves in 2, 3, and AVF. So left anterior ME block is definitely more common than left posterior ME block. Now with left posterior ME block, it is very rare but wild. Left posterior ME block is like the reverse or the mirror twin of left anterior ME block. What you have is that the axis is right. The Q wave is you find Q waves in 2, 3, and AVF, and then the small RS pattern in 1 and AVL. So you're looking for that S1 Q3 pattern. It can look like pulmonary embolism. So just keep your eyes open. Remember with pulmonary embolism, we're talking about the S1 Q3 C3 pattern. So this is the left posterior ME block. Now, if it's good to have all this knowledge, but like I said, whenever you see wide QRS complexes in any ECG, your signal should go up for blocks. And when the blocks are not looking classical, or when the QRS complexes, you're now finding them in 2, 3 AVF has been exceptionally wide there. If you find a Q wave, so you just need to remember, for example, if you now find a Q wave in 2, 3, and AVF, that should be alerting you. Am I dealing with a left posterior ME block, right? But if on the other hand you check it and you're finding a RS pattern in 2, 3 AVF, it should alert you as well, right? So these are the things to remember. But generally, why QRS complexes, look at the ECG properly and how is your patient doing. So we've talked about the left posterior ME block. The thing is, with left posterior ME block, it can mimic um, an old inferior MI, right? And don't fall for it. What it means is that there may be major conduction system damage. It is linked to anterior MI with poor prognosis. Before diagnosing left posterior ME block, rule out your right ventricular hypertrophy because they look similar. So don't label it unless you've ruled out your right ventricular muscle bulk. Um, um, okay, I believe we've gotten through. I really wasn't sure we had gotten through, but basically, I wanted to just explain to you what the blocks are. Let me know if you found this useful, and let me know if you have any questions or areas that you wanted me to address. Right? Thank you, and see you soon.